You're good to go. You're on. Wait a minute. I'm going to mute myself so that I don't add anything to this.
All right. Okay, so we're picking up minutes later, and we're going into parts that we didn't have time for in the main webinar. Because we have to respect the disc itself. We have to look into what else is going on in here. Okay. We have 60.4. That is likely an osteochondral patient. Didn't grow all the way on the right side, but they did on the left, and it's consistent with the problem on the right in the joints. In CNO3, we're not only doing a didactic lecture, we're forcing them to read lots of literature, and there's an exam. I would probably notice a tropism also. But essentially, Piper taught me this years ago, that if you disrupt the ligaments on a child, be it lateral or medial pull, there's a very good chance that you create an osteochondral growth defect. It's an XG3D that only shoots an 8 by 8 centimeters, so I can only get one joint at a time. If you look at the cross-sectional view or the coronal view in the center of the screen on the bottom, is 0.61 times 100 would be 61%. Slightly adapt, not really though, but the left side's a nightmare. That thing's falling apart. That is very unstable and maladaptive. Here's another example. The glenoid fossa, that upside down hillside that is the eminence, things look pretty good there. With the lingual inclines of the upper anteriors, especially in the excursive movements. And there's ways to read bites and look clinically to see if things are right or wrong, and I can kind of read into the orthopedics based on clinical presentation. But essentially the anterior guidance gets us off our posterior teeth. If all is well with the cartilage, then the bone, the eminence itself, the teeth, and a lack of intercapsular adhesions. If it's not well, we're on our posteriors much too long. So when I'm making these occlusal adjustments, I'm not just thinking one table leg, I'm thinking 3 table legs and how they're interacting and they're moving around in their excursive movements, because these occlusal adjustments are made in the excursive movements. And everyone's ignoring the disc. These are recipes. There's no diagnostic criterion in there. The cervical inputs, the sympathetic inputs that are innervating the lower mandibular molars. That's the cold swish. The range of motion, you all know what that means, vertical, horizontal. The CTs, those are important. That's part of our protocols. The MRI is as well. Old injury. And she saw myself, and she also saw Piper, and she would not accept the diagnoses. Or when there's John Radke in the middle, Brent Thompson on the right. John is the inventor of the BioPack, the engineer. This was CNO3 last October. Okay, this is Zibovitz and I up there lecturing. This is Piper and I with Steve Olmos.
Steve.
Yeah, you know Steve probably. And here's just a chiropractor. There's this guy works in Buckingham Palace, and the patient, he flew in from the UK. And here I have a chiropractor helping him with his C-spine.
Wow.
And that's it. That's the whole thing.
Wow.
So, Tom, I'll gladly, if you guys ever want to do, I'll get in front of a Windows computer. If they want me to show them, I'll just go through CT and MR.
We need to understand the questions to answer by looking around the corner and imaging before the clinician even knows to ask the question.
Yep.
So the more that they're rubbing shoulders with you and understanding the clinical challenges that you're trying to manage, the better that they're going to be able to communicate with you to answer those diagnostic questions.
Yeah.
It only makes sense.
Yeah.
It gives you real data.
Exactly. And you have a record of it too. You know, when I do fillings and crowns, the first thing I have my assistants do before I even numb the patient is I have them do a T-scan. This is a normal practice. This isn't even TMD world. You come in for the crown tomorrow, first thing we do is have you bite on that sensor and grind around. And then we have that in the record. And then let's say I do your crown, and in my office, you walk out 2 hours later, finished, because we're doing CAD CAM. I've done it for 12 years. I've cut half as much tooth away, and you're less likely to have any root canal problem or sensitivity. But before you leave, I check your bite again with a T-scan, and I compare it to the before. And then let's say you come back a week later telling me, hey, I'm sensitive. I'll look at the original T-scan data. I'll take a new bite now that you're not numb, and I'll compare them, and I'll make a swipe or two, and your cold will go away. And how I know that is because I had you swish with ice water when you walked in a week later, and I have you swish again. seconds after I make the adjustment, and guess whose teeth are no longer sensitive? And imagine what kind of shift we might make in the industry, in the profession,